Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/ctg. This activity is supported by an independent medical education grad from Madrigal Pharmaceuticals.
Hello, I'm Yki-Järvinen from the University of Helsinki, and I'm delighted to welcome Jeremy Tomlinson from the University of Oxford. In our previous activity, we covered the definition of MASH and its bidirectional link with type 2 diabetes, and we gave you an overview of the guidance and non-invasive tests for assessing MASH in the clinic. In this activity, I will briefly introduce MASLD, and then we will talk through a patient case and take a closer look at the practicalities of identifying and treating MASH. So our unhealthy lifestyle, overeating and physical activity are main reasons for why some people, although not all of them, develop a fatty liver. In those individuals who develop a fatty liver, there is inflamed and dysfunctional adipose tissue. There's an increased flux of free fatty acids to the liver and low adiponectin levels. Overeating, particularly simple sugars, stimulate de novo lipogenesis. In other words, there is synthesis of fat from carbohydrates, and also the free fatty acids get synthesized to fat in the liver. The liver becomes insulin resistant, which means that insulin no longer is able normally to suppress production of glucose, leading to a high glucose concentration, stimulation of insulin secretion, and an increased risk of type 2 diabetes. Similarly, insulin is unable to inhibit the production of triglycerides, leading to high triglycerides and ultimately also to lowering of HDL cholesterol. The fatty liver overproduces other cardiovascular risk factors such as coagulation factors and CRP. In addition to this, changes in lipids and glucose and insulin. So the increase in these risk factors in coagulation factors, lipids, and glucose all increase the risk of cardiovascular disease. Okay, so on the right-hand side, we see that components of what endocrinologists know very well of the metabolic syndrome are very important predictors of who will develop not only steatosis, but also major liver outcomes. We can see that if you only have hyperglycemia, shown here with the green line, the cumulative incidence of major liver outcomes is much lower than if you have 5 components of the metabolic syndrome. Thus, it's very important to identify components of the metabolic syndrome as they are major predictors of who is at risk of developing severe liver disease. And you also can see here that over approximately 10 years, some 2% of those with 5 components of the metabolic syndrome will develop a major liver outcome. So patients with components of the metabolic syndrome are at risk of developing steatosis, and our current definition of metabolic syndrome associated steatotic liver disease requests that the patient has steatosis and in addition one cardiometabolic criteria. Thankfully, the cardiometabolic criteria are identical to the components of the metabolic syndrome, so that makes life of the endocrinologist kind of easy. But of course, for the metabolic syndrome, you need 3 components. Here, it's sufficient to have just one. How common is steatosis in patients with type 2 diabetes? Roughly 65% have steatosis. So even when very carefully diagnosed. Not everybody has steatosis. There is a substantial proportion of patients who do not have steatosis. Advanced fibrosis, meaning fibrosis stages 3 or 4, where F4 is cirrhosis, has been estimated to be present in 14% of patients with type 2 diabetes, and clinically significant fibrosis in approximately 1/5 of patients with type 2 diabetes. So there are quite a few individuals who may require assessment and intervention for MASH. So let me just introduce a patient case, because I think that illustrates really better what we are dealing with as endocrinologists or diabetologists. This is a fairly typical patient. She's a woman who, at the age of 20, weighed 55 kilograms. At the age of 40, she had gained 20 kilograms. So that is 10 kilograms for 10 years, 1 kilogram every year. And she had gestational diabetes during 3 of her pregnancies. A liver enzyme was measured for some reason when she was 40 years old, and her ALT was found to be 70. So it was elevated, and an ultrasound was performed, and she was diagnosed to have a fatty liver. And at the age of 40, she was diagnosed to have hypertension. So she had a full-blown metabolic syndrome. And then time went on, another 10 years, another 10 kilos. And at the age of 50, her weight was 85 kilos, and her BMI was now 33. And at this point, this would have been the golden moment for the endocrinologist, diabetologist, to think about the liver. Her liver enzyme had been elevated already at the age of 40 years, and she had steatosis. So according to the current guideline, she should have here undergone assessment of her liver. And the question is, what should have been done? So now, please answer this challenge question. So I will now hand over to Jeremy to talk about the initial assessment of MASH.
Thank you. In this episode, what we'd like to do is to really just begin the first steps in understanding how we can stratify to identify those patients who may have those advanced forms of MASLD that may be amenable to intervention. Once we know that patients have a MASLD, then it's important to identify those who may be at risk of the advanced stages. That may include those patients with type 2 diabetes or obesity and other associated metabolic complications. The first step in identifying those patients most at risk of advanced disease may well be to calculate the FIB-4, which is a score that comprises both the age, the liver chemistry, the ALT and the AST, and their platelets. And that FIB-4 score allows us to risk stratify those patients into those that are either likely to have low risk of advanced fibrosis or those at high risk. And you can see that in the algorithm presented here. The algorithm here shows that those with a low FIB-4, less than 1.3, have a low risk of associated of having advanced fibrosis. In contrast, those patients that have an elevated FIB-4 score, those greater than 2.67, are the ones who are at highest risk of advanced fibrosis, at highest risk of adverse outcomes, both cardiovascular and liver outcomes, and those who would benefit from a dedicated hepatology referral. But there's a group of patients in what we might term the indeterminate zone, where those scores range between 1.3 and 2.67. And it's those patients where we need to think about whether additional tests or whether repeat assessment of the FIB-4 may be appropriate. To expand a little bit more, as I've already mentioned, the FIB-4 is a composite score that takes into account the age of the patient, their liver chemistry, their AST, and the ALT, and their platelet count. And you can see the equation shown here on the slide. One important consideration, though, is the age, because age is an important factor within the FIB-4 calculation. For those patients less than 65 years, a score of less than 1.3 makes you unlikely to have advanced fibrosis. In contrast, however, because age is a factor, and we know that this is a disease that becomes more advanced with age and is progressive with age, a higher cutoff of greater than 2 is appropriate for those patients who are age 65 and above. So in the patients with a lower age than the 65, less than 1.3 is appropriate. In those greater than 65, a lower cutoff of 2 is appropriate. If we look at the bottom row here, these are the patients who are at highest risk of advanced fibrosis, and that's the same for both age cutoffs of 2.67. And the indeterminate zone is where additional tests may be appropriate to try and risk stratify to identify non-invasively whether these patients have advanced fibrosis. The other important consideration is in young patients. And in young patients, those less than 35 years of age, the test performs poorly. And again, either taking this into consideration or using alternative tests may be appropriate. There are other conditions where the FIB-4 test may not perform quite as well as we would like it to do. And I've already mentioned, as you can see in this graph, the issue of age. But importantly, in patients with type 2 diabetes, the patient performs the risk stratification tool, the FIB-4, performs less well in patients that have diabetes as opposed to those that do have diabetes. And you can see that in the red box highlighted there. So it's important to take these things into consideration when we're understanding exactly how the FIB-4 test works. And in those patients where we have the indeterminate zone, additional tests may be used. And the most appropriate step, the next step, may well be what we call vibration-controlled transient elastography, which is a point-of-care bedside test that uses a vibration pulse to assess how rapidly that can be transmitted across the liver to provide an indication of liver stiffness. And that liver stiffness, in the same way that FIB-4 does, provides a cutoff that assesses your risk of having advanced fibrosis. So low liver stiffness measurements, for example, less than 8.0 kilopascals, provides a low risk of advanced fibrosis. In contrast, those with a liver stiffness greater than 12 suggest that you may be at high risk of advanced fibrosis. Interestingly, the VCTE also provides an assessment of steatosis through the controlled attenuation parameter. And again, that can be quite useful when we're looking at the amount of steatosis and in particular response to therapies, including weight loss, where we'd expect steatosis to fall. Now, please answer this challenge question. Thank you. And now I want to discuss alternatives to VCTE for confirming or identifying patients at risk of advanced fibrosis as second-line tests to the FIB-4. Thank you. In previous episodes, we showed how the use of a FIB-4 and VCTE can help risk stratify patients to identify those at highest risk of advanced fibrosis. However, there are alternative second-line tests that can be considered. One of them is the Enhanced Liver Fibrosis Panel, which is a blood and serum-based marker, which is a composite score of 3 different markers that can provide important information as to the risk of fibrosis. That includes hyaluronic acid, a pro-collagen terminal peptide, and a tissue inhibitor of a matrix metalloproteinase. And various scores have been proposed, but depending upon the score that composite blood test comes with, then it can make an assessment as to your likelihood of having advanced fibrosis, such that scores greater than 9.8 are suggestive of advanced fibrosis. Scores of, for example, less than 9.2 would be reassuring, suggestive of a low risk of advanced fibrosis. Importantly, there are other tests as well. Shear wave elastography uses a form of ultrasound technology to also provide an indication of your risk of advanced fibrosis. And again, bearing in mind the differences in body composition that are associated with a MASLD, this can be more accurate in patients with a central fat distribution and obesity. And again, cutoff thresholds for liver stiffness are proposed in terms of less than 8 kilopascals, making advanced fibrosis unlikely. Higher readings, certainly greater than 10.5, make the advanced fibrosis more likely. But there are also other non-invasive scoring systems that have been proposed, and many, many different markers, combinations of imaging, blood markers, have all been suggested to be able to predict liver biopsy, in particular the fibrosis on liver biopsy, and some of them presented here. I've already talked about FIB4 and ELF, but here we show data really from the AST to ALT ratio. BARD is a composite score that looks at patients with diabetes, as well as your liver chemistry and your BMI. And other scores, APRI and NAFL fibrosis score, again, use composites of routinely measured biochemical and anthropometric measures to try and make a non-invasive assessment of your risk of fibrosis. And you can see the ROC analysis here presented on the two curves, showing how well they perform. And I think the take-home message from this is that they perform reasonably well, with errors under the curves of approximately sort of 0.8. But none of them are perfect tests to be able to identify those patients with fibrosis. One of the most detailed or comprehensive assessments has been provided by the Litmus Consortium, which has used a constellation of non-invasive liver markers compared against patients that have had liver biopsy. And you can see here in the graph here, showing the area under the curve for the ROC analysis, and the dotted line really representing that threshold of 0.8, where we think there is clinical utility in the test. The take-home message I think you can see from this, and you can see both the VCTE as well as the FIB4, is that they all perform to a similar fashion, and none of them are perfect. And again, specifically in patients with diabetes, you can see the ROC curve there on the right-hand side. And again, the area under the curve for the ROC curves in parallel with the AUCs from the bar graph are all approximately 0.8 and similar across many of these non-invasive tests. What does that mean? Well, it means that none of them are perfect. It means that we have to interpret those tests in the context of the patient in front of us, and that they are providing us with an estimate of the risk of advanced fibrosis for that patient. So, what does this really mean? Why is it important to try and assess advanced fibrosis? And this is crucial because we know that it's the fibrosis that actually determines your clinical outcome. And all the things that we've talked about, the non-invasive measures, as well as liver biopsy to actually formally measure the amount of fibrosis, are important predictors of liver outcome and of survival. And you can see that in data presented here. So if you look at liver biopsy in the top left-hand panel, FIB4, the VCTE and the liver stiffness measurement in the top right-hand of the NAFL fibrosis score, another biochemical assessment of liver fibrosis risk, you can see that on the scores that provide most evidence for advanced fibrosis, for example, if you look at the FIB4 panel, those patients with a FIB4 greater than 2.67, it's those patients that have the poorest outcome. So non-invasive tests as well as liver biopsy that predict adverse outcomes are in those patients that have the most evidence for advanced fibrosis. So they help us decide which patients are most at risk and which patients are most likely to benefit from intervention. Now, please answer this challenge question. Thank you. I'll now pass you back to Hannah, who'll discuss the latest advances in liver-targeted treatment for MASLD.
We now have, for the first time, some specific therapies to treat the liver. Two new drugs, one of them is familiar to the endocrinologist, semaglutide and resmetirom, have now been approved by both the FDA and the EMA. The reason why these drugs were approved was that there were positive reports of their performance in phase 3 trials. One which used resmetirom was called the MAESTRO-NASH trial, and the one using semaglutide was called ESSENCE. All these patients underwent a liver biopsy before and after treatment. And here you see some of the characteristics of the participants in the trials. Quite similar amount of females, BMI fairly high, and even other characteristics quite similar. And liver stiffness measured by VCTE, which was just explained, was approximately 12 on the average in the MAESTRO and Essence, and 10.9 in the Essence trials. So all these patients had, based on the biopsy, fibrosis stage 2 and 3. And these patients were the ones eligible for these trials. There are two endpoints which are important when we talk about drugs used to treat MASH, called NASH at the time. One is NASH resolution with no worsening of fibrosis, and the other one is fibrosis improvement by at least one stage with no worsening of NAFLD activity score, or NASH activity, we could say. Here we see the results for resmetirom. We can see that the two doses used, the 80 and 100 milligram doses, both significantly resolved NASH without worsening of fibrosis. And in the middle panel, we can see that there was also significant improvement of fibrosis with no worsening of the NAFLD activity score. Interestingly, this drug, resmetirom, which is a thyroid receptor beta agonist, also lowered LDL cholesterol by 13 and 16% with these 80 and 100 milligram doses. So here we see a sub-analysis of this MAESTRO-NASH trial. And here we can see that resmetirom was effective both in patients who were using GLP-1 receptor agonists as well as those who did not. And this was true both for MASH resolution and for fibrosis improvement. Resmetirom was generally well tolerated. The most common side effects was diarrhea, occurring in approximately 27 to 33% as compared to 15.6% in the placebo group. And then nausea, which was the frequency was 22 and 18.9% in the resmetirom groups and 12% in the placebo group. The Essence trial was a trial where semaglutide was used, and this drug is familiar to you because the 2.4 milligram dose, which is injected subcutaneously once a week, is the same preparation as is currently used for treating obesity. But now here it was used to treat MASH with fibrosis stage 2 and 3. And we can see that there was a significant improvement in resolution of steatohepatitis with no worsening of liver fibrosis. And also there was reduction of liver fibrosis with no worsening of steatohepatitis. Interestingly, the placebo response rate was very high in this trial. Safety was consistent with established known profile of the GLP-1 receptor agonists. And here we have our next challenge question. Thank you. And now Jeremy will talk about the multidisciplinary management of patients receiving liver-targeted treatments for MASH.
Thank you. In previous episodes, we've discussed how we can risk stratify patients to identify those that are at most at risk of advanced fibrosis and who we may want to consider referral to our gastroenterology and hepatology colleagues. People may ask, well, what is the reason for referral? What can the hepatologist and gastroenterologist offer that diabetologists and endocrinologists can't do in their clinics? Well, I think there are many things. And what I want to show you over the next few minutes is the importance of working together to get the best for our patients. As we've already heard, there are now new licensed therapies specifically for liver indications. Resmetirom and semaglutide now have licenses to treat MASLD with advanced or moderate to advanced fibrosis. Importantly, within the context of the gastroenterology and hepatology clinics, there may well be access to additional trials or other interventions that might include bariatric surgery or other multidisciplinary approaches that could benefit our patients. Clearly, we want to try and prevent our patients from progressing to the most advanced forms of liver disease, to cirrhosis, and to decompensated disease. But that still does happen. And in some consequences, we have to consider liver transplantation for our patients that have decompensated disease. And that's clearly the remit of the gastroenterologist and hepatologist. But importantly, there's increasing need for metabolic input for these patients. So what would perhaps be the ideal structure of a metabolic hepatology clinic that could address the needs of our patients, bearing in mind the challenges that we face in managing patients with MASLD, and that MASLD is very much a multi-organ disease with multiple organs and multiple comorbidities often coexisting? So clearly, as we've already discussed, there's importance for hepatology input to help manage the liver disease, and also from the metabolic physician, the diabetologist or endocrinologist. And the first key element is really to ensure that the diagnosis is correct. And certainly we now have very active criteria in terms of being able to positively identify those patients who have MASLD. And we've already talked about the risk stratification tools, including FIB4, but also including VCTE, that can help us risk stratify patients to identify the stage of disease and identify those patients who are most at risk of advanced fibrosis. Clearly, we know that weight loss is an important strategy to try and treat patients with MASLD. We know that losing weight can halt the progression and sometimes improve MASLD. And that's an important goal for treatment within the clinic. And that necessitates involvement both from physicians, but also from lifestyle advice from dietitians and other healthcare professionals. We know that most patients with MASLD will actually die of cardiovascular complications, although there is a significant contribution of adverse liver outcomes in addition, but modifying cardiovascular risk is absolutely crucial. And that comes in various ways. We know the importance of lipid-lowering therapy, but important to ensure that there's improved and optimized glycemic control in our patients with type 2 diabetes, ensure that there is smoking cessation for those people who are smokers, adequate blood pressure control, and advice about exercise and diet are all crucial components to modify cardiovascular risk. We now are in the very fortunate position to have liver-targeted therapies, and therefore having a clinic structure that is able to offer those therapies, to be able to monitor them, but also to provide patients with the appropriate advice for when they're on these therapies is crucial. So it's really a combination of things that can provide the best care for our patients. This is a rapidly moving field, and clearly there's opportunities for participation in research, and that's an important element for patients because that provides them the opportunities for the newest and most advanced treatments. But what's really important is that we do offer a personalized, holistic assessment and management for our patients such that we can try and improve their liver to actually provide them with the best outcomes. And in the context of a multidisciplinary clinic, can they actually work? Well, this is just some evidence from real-world data that shows that if you look in the left-hand panel, that you can achieve meaningful weight loss in patients with and without type 2 diabetes in the majority of patients who attend a multidisciplinary clinic. With the middle panel, you can see that at baseline and then at follow-up visits, you can see that glycemic control can be optimized and improved in many patients with targeted therapies that can both improve glycemic control, but also cardiovascular outcome. And you can see that in the final graph on the right-hand side that looks at the Q-risk score, which provides an assessment of cardiovascular risk, and also liver stiffness measurements by using VCTE. And you can see how both those scores decrease 1 year after entry into the multidisciplinary metabolic hepatology clinic. So I think this is real-world evidence to suggest that actually the metabolic health and the liver health of patients can improve significantly with a multidisciplinary approach, combining both metabolic physicians and hepatologists to try and achieve the best outcome for our patients with MASLD. And now please answer this challenge question. Thank you. Finally, I will hand back to Hannela, who's going to revisit the patient case that she presented and set that in the context in the light of modern assessments and interventions.
Okay, let's get back to the patient case. We were describing the situation previously when the patient was 50 years old had elevated liver enzyme, diagnosed was steatosis. And if we would have been as wise as we should be today, we would have calculated the FIB-4 score, as Dr. Tomlinson was just explaining. But actually, this was not done, and the patient was just left. And actually, during the next 15 years, gained 16 kilograms of body weight. And then at the age of 65, the liver enzymes had decreased, platelets had decreased to subnormal levels, and actually the FIB-4 was now 7.5, whereas it was 2.0 when the patient was 50 years old. So ideally, the patient should have been sent to the hepatologist or for the VCTE exam here when the FIB-4 was 2, but this did not happen. But what happened was that the liver failed, and at this point, VCTE was done when the patient was 65 years old, and the value was 21, which is way too high and indicative of liver cirrhosis. The liver biopsy was done, and the patient had MAS cirrhosis, and also gastric varices were diagnosed. So one can just hope that now with these new guidelines and tools, and the tools which are available, that these kind of deterioration of liver function could be avoided, and actually therapy would be started, and the patient would not have this unfortunate condition. Okay, so now please answer this challenge question. Thank you for watching. So Jeremy, I was really excited to hear that you already have a multidisciplinary team at Oxford working with these patients, and I wonder, was it difficult to set it up, and could you perhaps describe what kind of specialists are included in your team and how it works?
So the clinic is effectively run jointly by metabolic physician and a hepatologist. But alongside that, we're very fortunate in the position to have a lifestyle team who have both exercise physiologists, dietetics, and we can refer patients directly as part of our clinic structure to that. We also have specialist nursing input and also clinical trials and research input. So we do have that multidisciplinary structure. And I think that's important because, clearly, as we've said throughout all these educational pieces, that MASLD is very much a multi-organ disease. It's not just about the liver. And that translates both not only to how the disease develops, and I think you've shown that very nicely in the pathogenesis figures that you've shown, but also in the outcomes. We know that actually it's not just about liver outcomes, it's about cardiovascular outcomes as well. So I think having physicians and expertise within a clinic structure that can think about how best to manage the liver, yes, and how to perhaps use liver-targeted therapies. But actually, what we mustn't forget is that most of the patients that we see in our clinic, it's the cardiovascular adverse outcomes that will be most important. And so in those patients that we have, uncontrolled diabetes, what can we use that's the most sensible approach? How can we tailor their glucose lowering therapy that has additional benefits both for liver, for cardiovascular outcome? What about stopping smoking? What about physical activity? Physical activity is something that I think is very hard to get patients to do, partly because of the infrastructure, but that's something that we know can improve the outcome in these patients. So we're fortunate that we do have many different healthcare professionals from different backgrounds, and I'd like to think that we can offer holistic. But importantly, I suppose, whilst we're in the fortunate position that we have many individuals that could deliver that, as an individual clinician, making sure that you are, open-minded and can think that there are multiple components. We often, tend to work in silos. And I think by thinking outside the box a little bit, saying, okay, fine, I'm a endocrinology specialist, but actually, what about the liver? Or I'm a liver specialist, what about the metabolic phenotype? All those things are important when we see the patients in front of us.
Yes. So this is really not the guidance is not just to refer the patient to the liver team. It is much more than that.
I think that's right. I think we have to know that these patients have chronic, multiple long-term conditions, weight management, diabetes management, hypertension, all great examples from your case. And you can see how they evolved over time. And the management of their MASLD includes the management of those comorbidities. You can't hope to get the best outcomes for the liver if we're not treating their diabetes, if we're not trying to control their weight, if we're not trying to control their blood pressure, make them as physically active as possible. So I think all those things go hand in hand with trying to get the best outcomes for their liver.
And may I ask you about VCTE availability outside? I'm sure you have it in your multidisciplinary clinic, but how is it outside? Is it, does the patient have to be referred to a hepatologist to find the VCTE, or do you have it available in other places?
So generally speaking, yeah, it's within the clinic structure. So every patient that comes to our metabolic hepatology clinic will have a VCTE. So it's available in secondary care, in the hospitals, in the dedicated liver clinics. It is not available in the vast majority of cases, this is specifically within the UK, in clinics outside of hepatology. Although there are moves to try and get VCTE out in the community, to use it as a community risk stratification tool, because we have to realize that actually most of the patients with type 2 diabetes and with obesity, the two big risk factors that drive MASLD, are not within the context of secondary care. Most of those patients are in primary care. So I think there's a great disease burden that we haven't really recognized. We know that from data that you showed, a significant proportion of patients with type 2 diabetes will have advanced fibrosis and indeed cirrhosis that isn't recognized. So I think not only thinking about how we can risk stratify those patients in the context of hospital clinics, but perhaps more importantly, from a sort of a more global perspective, what about those patients out there in primary care? What are we doing about those patients? How we should assess their risk of advanced fibrosis, because it's important that we diagnose those to give them the opportunity to get the best therapies, to make the best chances for them to have the best outcomes.
Yeah, and it's also what we perhaps didn't emphasize enough, that just relying on liver blood tests is not sufficient to diagnose anything. So because in most patients with MASLD, the liver enzymes are normal, so you really can't say that everything is okay if the liver enzymes are normal. Of course, when severe liver disease develops, then they even if they have a little bit elevated, they will decrease back to normal. So we really need to use these other tools we discussed to diagnose these patients.
Completely agree. Absolutely. We can't rely on simple liver blood tests. We have to be more sophisticated. Agree.
Well, thank you, Jeremy, for this, and thank you everybody who took the time and listened to this, and let's hope that this is for the best of the patients. Thank you.
This has been an activity published by Peer Voice.